Thank you so much for your kind introduction. Thank you all for being here. And it's always good to be among colleagues and friends and to speak about something that I really like. And that's about the role of therapeutic patient education. And I'm just going to choose to speak about communication. And for a specific example, because we know that people living with diabetes, they most seldom have complications, the cardiometabolic complications. And I would like to propose how and your to raise your curiosity on how do we discuss cardiometabolic risk to our patients. And I have an example here of my city, Lisbon, in Portugal, and that's a picture from the present days. And almost 300 years ago, we had a big earthquake, and most of the city was destroyed, and there was flood, everything a tsunami. And still we live in a seismic area, but if you ask people, they don't know nothing about that risk. So even if you are confronted with the reality, it's really difficult to really incorporate that risk and adapt your strategies to live with that risk. And the same perhaps happens with the cardiometabolic disease. So when we look at the internet to find what is cardiometabolic, I found this from the Cleveland Clinic. They say from the Center for Cardiometabolic Health. So again, it's a new concept, cardiometabolic health. And in the same paragraph, they spoke about cardiometabolic risk factors. And they say cardiometabolic risk factors are a group of conditions. So we have disease, risk factors, group of conditions. And then they say that those risk factors cause heart and vascular disease. And then they give an example of what are the cardiometabolic risk factors. And we have diseases there, diabetes, we have dyslipidemia, hypertension, obesity. And then they try to explain to you, and you imagine that you as a patient, those factors increases your chance for early and severe cardiovascular disease. So it's really not a clear message when we try to speak about something that for us, healthcare providers, is quite clear. And then, still in the same web page, it says early diagnosis and treatment not only reduce the risk, so the concept of risk is there, but also prevents the onset and progression of cardiovascular disease. And then, as we often do, we try to speak on numbers to convince people. And look at those numbers and see how much are you convinced about the relevance of the cardiometabolic health. It says that 2 out of 3 patients with diabetes will die of heart disease. Does it matter for someone living with diabetes? They say that nearly 50% of Americans have diabetes or pre-diabetes. Your risk of cardiovascular disease is 2 to 4 times higher if you have diabetes. Women with diabetes have a higher risk. And then you can reduce your risk of heart disease by getting comprehensive treatment. Again, are we communicating in the right way? Are we saying to people what they really need to know to change their behavior? Is this the role of information? So what are we speaking about? And just to, again, on the left-hand side, you have from 2 papers when they speak about cardiometabolic disease. In the first one, they say cardiometabolic diseases are CVD, type 2 diabetes, chronic kidney disease. In the second paper, they had obesity. Then sometimes we are still speaking about metabolic syndrome. And they are all related. But imagine that people hear this from different healthcare professionals. We are giving mixed message or wrong message or a lot of noise about a very simple concept. And then sometimes, even for us, we try to show what is cardiometabolic disease, showing all that interaction between different mechanisms. And we try to see that as a simple mechanism to explain. And again, is not simple. So my first challenge to you is to say that all these concepts, it means that even for us, healthcare professionals, we are not sure what we are speaking about. And when we are not sure, if we try to convince others to move in a right direction, perhaps we are not doing a great job on that. On the second part, and I spoke about our role of healthcare providers, that usually say, well, we know a lot, but patients are unmotivated, they have poor health literacy, under resources, and it's an explanation why we are not getting there. And that's the role of TPE. And again, I always show this picture of my association, the Portuguese Diabetes Association, that was founded in 1926, where TPE is provided since almost 100 years ago in group lessons, personalized face-to-face consultation, and actually the education was provided for poor people living with diabetes. It was the reason to create the association. And so we provided insulin for free, education. That was the beginning of association. And then in the 70s, we had this paper from Leona Miller, again in a poor setting community in Los Angeles, just showing that providing education, changing the way we give the consultations or give access to people living with diabetes, it made a huge difference in outcomes, and Tatiana just mentioned outcomes. And in this case, they were measuring something very simple, the need for people to go into emergency rooms. And providing education, as you can see in the yellowish part, it reduced the number of people getting to ERs because they had another way to communicate with healthcare providers. So education was effective. Tatiana has already mentioned, and Purvi also mentioned the therapeutic patient education. So it's a structured, person-centered learning process. It is carried out by trained health professionals. It should be adapted to patients and their condition. And so it's an individualized process. It's an integral part of the treatment for chronic condition. And the idea is always to lead to better health outcomes, poor quality of life, and making the best use of healthcare services and other resources. So it's not only good for patients, it's only good for the healthcare professionals, and it's good also for the health system. All those dimensions are incorporated when we speak about therapeutic patient education. And then the second part of this slide just show that sometimes we go immediately to the second component. So we think, well, this patient needs to know about hypoglycemia or should know about food. And we immediately go to give him a leaflet on the healthy food, the right food, the wrong food. But we miss sometimes that first stage there with the patient to define goals, actions, and that process of shared decision making. And if you don't do that first part, actually patients don't feel capacitated to take decisions. They don't feel empowered to incorporate that knowledge, and they don't have the confidence to change. So we sometimes, even when we have low resources, we try to complain that we don't have access to educational materials, but perhaps we could do a better job just doing that first part and discuss with the patients what they really need in their perception, what we think they need in our perception, and try somehow in the middle to find a common ground and start from there. And then it's where do we deliver education? Again, that's the APDP, my association again. And we try to deliver nowadays education in our daily life, in daily consultation. So not always patients have the time to go to group education. And so we try to give education in a structured way during the consultation. And we build this structure about in a single consultation to have when we meet the patient, when we collect information, how we go to share decision, and how we plan the end of a consultation. Third point here, to discuss and to communicate to whom, how, and when. Most of the guidelines recommend that we, healthcare professionals, engage patient, explain cardiovascular disease risk, but do not describe how to communicate these risks most effectively. So it's a little bit how Tatiana showed. We discuss a lot about therapies for type 2 diabetes. Education is there, but actually most of our time we discuss what are the drugs for the first line, second line, third line, and so on, and we don't discuss education. So it's really important to engage on education. Because when we speak about risk, this was a paper published some years ago, 4 years ago, 5, and there is a mismatch between self-perceived and calculated cardiometabolic disease risk. So when we ask patients with a high risk of developing cardiovascular disease and give a scale, a Likert scale, and say, put yourself where you think your risk is, as you can see, they were almost all high-risk patients, and most of them, they didn't feel that they were living as a high-risk population. So, again, there's a mismatch between patient perceptive and our perceptions about that patient, how we calculate that. If patients have a positive family history of type 2 diabetes, of a cardiovascular disease risk, if they were overweight or obese, if they know they were inactive, they would perceive better their risk because they were confronted with that. They have a clear perception what was to live with diabetes, inactivity, being obese. Other factors were not relevant for their risk perception. And another example, how do we communicate? Imagine that, and sometimes we do that with patients. We try to communicate risk. Imagine those three strategies there. Telling a patient that he has a 15% 10-year risk of cardiovascular event. He has a 4% risk at 10 years of death, of dying. A 50% lifetime cardiovascular disease event risk. And in this paper, they try to communicate those risks, considering exposing patients only to numbers, a bar graph, face pictogram, or nothing. And they try to understand if people perceive the risk high or lower. And if, based on that concept, they were willing to change medication or take medication, in this case, the statins. To tell you what was more effective, so when we speak about a 10-year risk of cardiovascular disease or death risk, actually was not very effective. When we speak about a lifetime, people would perceive better their risk. And considering the way you present the information, the right part of the slide there, actually bar graphs or just nothing, just explaining, I think sometimes to explain patients, it was better than showing pictograms that you usually think are the best ways. We show pictures, we show smiley faces, sad faces. Actually, it was not effective on communicating risk. Actually, not showing nothing. Again, remember my point on educational materials. Sometimes we don't have to have educational materials. Sometimes we just have to know how to communicate with patients. And then about also that happens also in primary prevention, when we try to communicate risk, if you see the bottom line here, we want to associate risk factor modification and behavior change. We want to improve risk knowledge and understanding. We want to have a better acceptance of the communication strategy, and we want to increase intentions to change. And if you can see, there are different strategies there, but the way you use it, it's that it has to be adapted again to patients. So imagine that you just have group education when you gather all the people. You give exactly the same information. If you don't provide space for people to express their feelings, you are not going to be successful. We spend resources on that, and actually you don't get to the point you want. This was published this year, just in February, at the beginning of the year, about how we communicate about weight loss. And some techniques that are there, they are just provided here to show an example of what can we do in easy communication. So for this case, how to initiate communication? Mention a time when weight has been discussed previously. Soften your language. Language is really important in this process. Incorporate those meta assessments. Referencing back, you mentioned earlier something about the disease. Ask questions and tailor response. So we should really ask questions and listen to patients, what they reply to you. Accept patients' response, include optimistic projection for the future. We always try to threaten people with complications, but it's not so good. We should use explicitly positive words, use a positive tone of voice, and clearly state the treatment options, and Purvi has also shown that, provide detail on where and how treatment can be assessed, cost, emphasize the next step. Those are all effective. And to show that what we do matter, in the same study, there is a clear association between education about communication and risk reduction, primary prevention or in secondary prevention. I just call your attention to the last bit of information on the right when it says clinician prescribing, which is not significant, meaning that we healthcare providers are the worst persons to change our behavior even when prescribing. We know that patients have high risk for several consultations, which like communicate the risk, and actually we don't change our prescription. And so we always blame the others, but we are ourselves to blame. And lastly, I've shown this picture also because when I was in North Macedonia, there was a pack of sugar with this. And when we spoke about the menace and the threat of sugar, and then when we see something, and today is Valentine's Day, so when we see this message that you are sweet as sugar, we really have the society pressure to show you another way, different from what we healthcare providers prescribe. With that, I conclude. I try to show a little bit of the concept of therapeutic patient education, discuss this process of how to communicate. And again, with that, I show the example of cardiometabolic risk, something that we use a lot, but it's so difficult to explain. Again, thank you very much for your attention.